So somebody asked about IIH, which is idiopathic intracranial hypertension, also known as pseudotumor cerebri, in PAH, which is pulmonary arterial hypertension. So when we have pulmonary arterial hypertension, that means the pressure is high in the pulmonary artery, and that's normally caused because we have occlusive disease in the pulmonary arteries that leads to increased back pressure, and that back pressure is going to go to the right ventricle. So we got right ventricular hypertrophy and right ventricular dilatation from increased pulmonary artery pressure. And you have to measure it, of course, to make the diagnosis. That's outside of the scope of practice of ophthalmologists. And the reason you need to know about it is the right heart is connected to the venous drainage. And so the mechanisms by which we could get papilledema that mimics idiopathic intracranial hypertension in a PAH, a pulmonary artery hypertension, are the same mechanisms that we see in obstructive sleep apnea. Obstructive sleep apnea also is associated with IIH, especially in men, and it is this obstruction in sleep associated with apnea that causes this increased intracranial pressure. So the apneic episodes can lead to decreased oxygen levels. That hypoxia can lead to secondary red cell production, polycythemia vera, and that could lead to the hyperviscous state that could cause a venous sinus thrombosis. Alternatively, apnea can increase your CO2 levels, that is hypercapnia. That's going to lead to vasodilation, and under the Monroe-Kelly doctrine, increased blood flow on the venous side will increase the intracranial pressure. And the obstruction is what's causing the problem to begin with in obstructive sleep apnea, and that is going to require forced expiratory effort against a closed glottis at night to open the airway. That Valsalva maneuver will be transmitted as increased venous pressure into the jugular and right up into the head. In PAH, we have the apneic episodes causing hypoxia and CO2, but because of decreased pulmonary function, not from stopping breathing. And there's no obstruction, but we get the same kind of phenomenon, increased venous pressure. So they're analogous, but they're not the same. So lung disease from obstructive sleep apnea or COPD and lung disease from pulmonary arterial hypertension can both produce papilledema, leading to something that looks like IIH because their brain imaging is normal or might only show evidence of increased ICP, and their spinal tap shows elevated ICP. But you should know that things in your lung and things in your chest and things in your neck can still cause increased intracranial pressure. And one of those things is PAH. The other thing you should know as an aside is PAH is sometimes treated with the phosphodiesterase 5 inhibitor, PD5 inhibitor. And that means even if it's a lady, she might be on tadalafil or sildenafil, which are the erectile dysfunction agents. And those, as you know, have an increased risk, probably 2.3, something like that, X risk of NAION. And so that's the other thing you need to know in neuro-op about pulmonary arterial hypertension.